The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day to all of you TMD warriors out there. We're gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today's episode is entitled, and the topic is, what is mewing? I'll repeat that as it sounds, mewing, and what does it have to do with TMD? So this podcast has everything to do with TMD. And this concept of mewing, which has nothing to do with cats, has quite a bit to do with TMD. Some of you, or maybe all of you who are watching right now, maybe have never heard of mewing. But among our adolescent components in the United States, and I think throughout the world, have been paying a lot of attention to this medical theory about mewing. So what is mewing? Mewing is a proposed method of enhancing and improving facial growth developed by Dr. John Mew, a British orthodontist in the 1970s. And his son, Dr. Michael Mew, has continued to promote his father's method. So first of all, let's define, as we usually do, if we have a word that needs to be defined. As Voltaire emphasizes, if you are to converse with me, first you must define the definitions. So what mewing is, according to doctors Mew, John and Michael, it is a method to correct and improve facial growth and position of the jaws, along with other things, by placing the tongue in the roof of the mouth behind the upper front teeth, and with the mouth closed, push forcefully with the tongue into the roof of the mouth, into the palate. That is the mechanism for mewing. And to do that several times a day, and as I read, propose 20 minutes per session, and do it multiple times, at least twice a day. And their theory is that by doing this, it has profound changes in the maxillary facial components by, number one, driving the maxillary arch wider, and improving the amount of airway space within the mouth and posterior pharynx, changing the growth factors of the entire face, and improving or helping to improve patients with sleep apnea, where there is obstructive sleep apnea, where there's obstruction while sleeping. And that is a lot to claim. And again, I chose this topic because I'm aware that on TikTok and other social media sites, adolescents are trying to do this to help what they believe are facial cosmetic deficits, whatever that might be for an adolescent. In so doing, I will give you, a little heads up and a little spoiler alert that can have profound negative effects on temporomandibular joint symptoms, on temporomandibular joint disorder, and actually creating symptoms. So I'll explain as we go on how that is. But if you know of someone who thinks they are doing something good by mewing, I can assure you, based on my own personal experience, my studies, my knowledge, and the studies of many others, that it is not a positive thing, it is a negative thing. So now we know what mewing is. How does that actually roll out in the real world? This is a very controversial claim and have been routinely debunked by mainstream orthodontists and dental researchers. And as I said, adolescents are taken to this. If you have a deficient mandible or a facial profile deficit of some kind, the claim is it can improve it. My own credentials in discussing this, I think, are significant. So I must admit, having the credentials to actually just make a comment on this, and I think most of you, or if you not, who watch these episodes, I think this is the 193rd episode on this podcast entitled TMD Demystified. You're familiar with my credentials, but I am not only a dentist with a DDS from Indiana University and a master's degree in cell biology and anatomy from Indiana University, medical degree from Vanderbilt University, and fellowship and grant from the NIH, NIDCR, National Institute of Dental and Craniofacial Research, with emphasis on facial growth and development. And back in the late 70s, I proved that you could create animal models using laser in conjunction with intrauterine fetal surgery to create animal models with reproducible facial defects that could then secondarily be used for other purposes in studying growth and development of the face. So with that as a background, I claim to know a little bit about facial growth and development, along with many others. So I want to just make sure that you understand that if I make a comment on that, it's just not made offhandedly on this thing called mewing. And it has been, quote, unquote, debunked by others. But you need to understand, if you know anyone or you're prone to do this, the effect that this can have on the temporomandibular joint itself. So the iconic textbook on facial growth and development was authored by Dr. Donald Enloe back in the late 60s, early 70s. I have literally read that textbook word for word twice. It is the authority. It is the authority on facial growth and development by Dr. Donald Enloe, PhD. And in that textbook, Dr. Enloe describes exactly how the facial growth develops, why it develops, how the bone enlarges or doesn't enlarge, creating what everyone has, which is a face, and how the different components of the face are derived from facial growth centers. There are certain facial growth centers within the face which allow us all to look differently. And depending on how those facial growth centers grow, will determine how your face looks as you become an adult. And of course, the face begins to grow intrauterинely, and then after birth continues to grow. And there are many, many effects on the facial growth centers, the centers of facial growth, that affect us how we grow, and things that can be done either positively or negatively to enhance or limit facial growth in many ways. So just because you have a set of facial components at birth doesn't mean that it can't change in one direction or another as time goes on. So definitely, as children grow, there are things that can be done to enhance facial growth to some degree. As a practicing oral and maxillofacial surgeon, practicing what generally spoken of as facial reconstruction, the proper term that is used most often is orthognathic surgery, changing the position and size of the face from the bottom of the eyes to the bottom of the eyes to the bottom of the chin, the lower face, can be changed dramatically by what is called orthognathic surgery, where a surgeon like myself goes into the operating room and makes specific, coordinated, planned cuts on the jaws from, again, the bottom of the eyes to the bottom of the chin in various positions that can change the function and aesthetics and cosmetics of a face. I would assume that there are any non-surgeons watching this. It may come as news, but basically with enough planning, a maxillofacial surgeon in conjunction with the help of an orthodontist, because once you change the position of the jaws, the teeth are not going to fit together the way they used to. So this thing we call orthognathic surgery is almost always done in conjunction with the help of an orthodontist who positions the teeth in the proper position so that when the lower face is moved into its planned position, that everything comes together nicely and functionally and aesthetically. And that has been done now for 50 years, routinely. And nowadays, this is actually planned on a computer, just like you'd plan anything on a CAD/CAM computer. It can be planned on a computer and based on facial photographs and facial x-rays, both from the anterior and from the lateral position. 3D models can be made on a computer, and the surgery itself can be planned on a computer with the cuts on the computer, which is all then duplicated in an operating room on a patient. So literally, and I say this with some hesitation because I don't think it needs to be used, at least very often. Theoretically, a maxillofacial surgeon with the help of an orthodontist can change someone who has a rather uncosmetic, let's just call it uncosmetic face, to a Hollywood face without any problem. Because the skeleton determines really what the face is all about. This stuff, which I have, same amount I did when I was 16, but it's, as I grow older, it's all sagging and leaves you with wrinkles and leaves you with all kind of things on your face. But this is just the covering. It has very little. You can see what happens if you just take away a little bit of skin. It has very little to do with the actual facial appearance. You know, if you did this, I mean, this is how I looked when I was 40 years old. So this facial skeleton really determines how a face appears to be. And that facial skeleton can be changed any way a surgeon wants to. So you could take someone with all kinds of cosmetic deficiencies, which would be in their mind, not the surgeon's mind, and change those into something quite different and quite cosmetically pleasing if necessary. But that is just a little side issue to tell you that orthognathic surgery really has a lot to do with the health or non-health of the rest of the facial skeleton. So jumping ahead to one point, what I learned as a researcher and fellow with the National Institute of Health doing this surgery and proving that you could create animal models during intrauterine fetal surgery stimulated by a laser is that the primary growth center of the lower face is the temporomandibular joint. It isn't the only growth center, but it is the primary growth center. So you can conclude, and what I did discover in my studies in using the laser on fetuses in the rabbit was the animal model that I used, that if you damage the temporomandibular joint, in this case with a laser intrauterинely, it can create profound negative changes on facial growth and development in a rabbit. That particular series of experiments was extremely exciting and extremely valuable, which was done many years ago. But it makes the point that anything that, my point is that anything that changes the health and well-being of these joints that we call temporomandibular joints, TMJs, the disease itself is described as TMD, temporomandibular joint disorder. The joints themselves are TMJs, temporomandibular joints. Everybody has two of those. In our culture, everybody calls the disease, or almost everybody calls the disease, TMJ, and it is a huge disease. TMD is a huge disease, primarily females. It's 45% females, 5% males, or you could say 90% females, 10% males. We're not sure exactly where it lies, but it is extremely more common in females, 90% females. It is a female disease because of this one fact that has been in the literature for better part of 50 or 60 years, which is estrogen exacerbates inflammation. I'll repeat that, estrogen, female hormone, exacerbates inflammation, and inflammation drives all of the symptoms associated with TMD. Inflammation is also responsible for fibromyalgia. That is why females are exclusively have fibromyalgia, and females have 90% of the patients with TMD. So the point being, back to these joints, the temporomandibular joints have a profound effect on facial growth and development and can be affected by many, many factors as the face grows in adolescence, in children, young children, middle-aged children, middle school children aged, and adolescents. All right, back to mewing. Mewing is this thing that is taken off somewhat virally on the internet, where our adolescents in our communities think that by forcing their tongue routinely into the roof of the mouth is going to help their face structures improve, which has not only been debunked by others, but I totally agree with them. It has no effect or no positive effect at all. By the way, the tongue does not have anything to do with facial growth and development. It fills the space. Whatever space is in your oral cavity is filled by the size of the tongue. So the tongue can expand into the space, but the size of the tongue does not create the space. Again, I'll repeat that. The tongue is nothing more than a major, it's 100% muscle with a few nerves and blood vessels in it. The tongue is 100% muscle. When you constrict it or push it, it can create a lot of force, but basically the tongue just occupies whatever the oral space is. So if you have a large maxilla, a large upper jaw with a large arch, a large volume of the arch, upper arch and lower arch, mandible, then the tongue will grow into that space, be allowed to grow into that space, but it does not create the space. If you have a very narrow upper arch, with our orthodontic colleagues struggle with not infrequently, it isn't because you have a narrow tongue. It's because the growth factors and the growth centers in the face have not allowed the maxillary arch to grow widely and ends up narrowly. And a problem like that, there quickly becomes not enough room for the tongue because the bones narrow the space. So again, the tongue itself does not actually have anything to do with growth and development. But if you practice this mechanism, this procedure called mewing, you can spread the teeth apart over a period of time if you do it enough, because teeth will move through bone with enough force. That's what orthodontists do day in and day out. They put forces, controlled forces, on teeth in three-dimensional directions and can move teeth through bone, especially through adolescent bone. Once we get to be adults, the bone gets harder and thicker and is very hard, much harder to move teeth through adult bone, but very easy to move teeth through adolescent bone, and extremely easy to move teeth through children, earlier than when the permanent teeth come through, and that's why orthodontists don't routinely do their treatment on children before they start getting in their permanent teeth. There seems to be really no reason for it. That was just extra information for you. So back to mewing. So here's the problem. Here's the problem why I am talking about mewing at this time on a podcast having to do with TMD. The problem with mewing is when you do that, the adolescent does that, think it's going to be helpful. What they're doing when you do that is naturally, by forcing the tongue in the roof of the mouth, you are forcing the lower jaw or mandible back posteriorly. And when you do that, you put extra loads on the temporomandibular joint. And we know very well by experience and routines and experiments, by overloading a joint, any joint, including the temporomandibular joint, if you overload a joint, it creates damage. The response of the body from damage is inflammation. Inflammation is the body's response to damage in an attempt to heal. For those, again, who are not geared or educated in the sciences, in the health sciences, inflammation is nothing more, nothing less than the body's attempt to heal. Sometimes it's effective, sometimes it's not effective, and is not successful. But 100% of the time, if there is an injury to the body's natural response is to create some type of inflammation to try to heal that offense to the body. A cut, a bruise, surgery on the face, on the belly, you name it, bacterial infections, all these things actually, to one degree or another, create different aspects of inflammation. Inflammation is a very complicated series of events, very, very complicated series of events, many of which we already know, some of which we don't know and are still working on. But chronic inflammation is created by damage to the joint, and mewing will force the mandible back, posterior, rearward, putting extra loads on the temporomandibular joint, and over time it can damage the tissues and structures within the temporomandibular joint, which in turn create chronic inflammation, which in turn will create the symptoms of temporomandibular joint disorder. The symptoms being frequent or recurring, and this I've talked about as recently as the last episode and multiple episodes before, the well-acknowledged symptoms of temporomandibular joint disorder are frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, which is fullness in the ear, feeling of fullness in the ear, dizziness and vertigo. They're not exactly the same thing, but they're similar. Vertigo is when either you feel you're spinning or the room's spinning. Dizziness is just that kind of whooshy feeling when you get up. Upper back and shoulder pain and tightness, arm, hand, finger, tingling and numbness, arm, hand, finger, tingling and numbness, and various kinds of jaw locking. Those are the well accepted. There are some other secondary symptoms that I don't want to go into now that some of you may want to dispute, but I'm finding more and more that they're indisputable. But those ones I mentioned are the accepted symptoms associated with chronic inflammation within the temporomandibular joint. And when our adolescents, our children are out there trying to change their facial structure by forcing their tongue into the roof of their mouth, they're not helping anything, and they may end up with some of the disparate symptoms of temporomandibular joint disorder. That is what I have to say about mewing. It's not a good idea. I won't try to characterize Dr. Mew or the doctor's Mew as not having good intentions. There's a lot of things you can read about the doctor's Mew, but their theory is just a theory. Their method is one of many methods that has been proposed by doctors throughout time, not just recently, but back time, trying to handle problems that really don't pan out. I think that's it. I've made my point, and as usual, let's just go on and not just blabber about, just to fill the schedule. If you would like to find out more about TMD, it can be reviewed. Myself, our practice, our company that actually has determined the true mechanism for temporomandibular joint disorder, and then from that, figured out how to treat it non-surgically. The website is www.urbanictmj.com. I'm available for emails at tony@tmjservices.net. That's tony@tmjservices.net. I am be pleased to communicate with anyone about any topic regarding TMD that I can help you with. As a young man, I found out that I had two purposes in life. The first purpose was to fix things, which I did greatly as a maxillofacial surgeon, doing reconstructive surgery. And the second was kind of similar, to help people. So if you are in the line to want to discuss this in any way, shape, or form, you're welcome to give me an email. I'll be happy to respond to that. So for today, I look forward to the next time, next week, next Tuesday. It will be on a Tuesday, where I record these episodes, and we'll pick another topic, and hopefully it'll be helpful to you, whether you're a professional or public. It'll be helpful to you to understand this conundrum that we have operated under for the past 50 years, which I now call TMD Demystified. Thank you very much for your attention. I look forward to the next time that we'll be together.